Have you ever wondered why so many people with high blood pressure feel completely fine, yet their hearts, kidneys, and even brains are silently getting damaged? Or why sometimes, even when a patient is taking all the right medications, their blood pressure just won't come under control? Today, we're diving into everything you need to know about hypertension medications, from every single class, how they work in the body, to why certain patients respond differently. By the end of this video, you will know exactly which drug does what, why it's chosen, how it works, and what side effects to watch out for. So if you want to truly understand hypertension pharmacology, stay tuned, because skipping any part of this video could leave gaps that cost marks in exams or even affect your clinical decisions. Hypertension, or high blood pressure, is one of the most common chronic conditions worldwide. It's called a silent killer because many patients feel completely normal, yet persistent elevation of blood pressure gradually damages blood vessels and vital organs over time. When blood pressure remains high, the heart has to work harder, blood vessels lose elasticity, and organs like the kidneys, brain, and eyes slowly sustain irreversible damage. To manage hypertension effectively, clinicians rely on 5 major classes of antihypertensive medications, each targeting blood pressure through a different physiological pathway. Let's begin with ACE inhibitors, also known as angiotensin-converting enzyme inhibitors. These drugs work by blocking the enzyme responsible for converting angiotensin 1s into angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor, meaning it causes blood vessels to narrow, increasing systemic vascular resistance and raising blood pressure. By reducing the production of angiotensin 2, ACE inhibitors cause blood vessels to relax and widen, which lowers peripheral resistance and reduces blood pressure. In addition to this, ACE inhibitors reduce the secretion of aldosterone, a hormone that promotes sodium and water retention in the kidneys. When aldosterone levels drop, more sodium and water are excreted, blood volume decreases, and blood pressure falls even further. Common ACE inhibitors include captopril, enalapril, lisinopril, ramipril, fasinopril, perindopril, and quinapril. Most ACE inhibitors are taken orally. Some are prodrugs that require activation in the liver, and the majority are eliminated through the kidneys. Clinically, ACE inhibitors are widely used in hypertension, heart failure, post-myocardial infarction management, and diabetic nephropathy because of their protective effects on the heart and kidneys. They are contraindicated in pregnancy, in patients with bilateral renal artery stenosis, and in anyone with a history of angioedema. Common side effects include a persistent dry cough caused by bradykinin accumulation, hyperkalemia due to reduced aldosterone, and rare but life-threatening angioedema. When prescribing ACE inhibitors, clinicians must regularly monitor blood pressure, kidney function, and serum potassium levels to ensure safety. Next, let's talk about angiotensin receptor blockers, commonly known as ARBs. ARBs block the angiotensin II type 1 receptor, preventing angiotensin II from exerting its vasoconstrictive effects. Unlike ACE inhibitors, ARBs do not increase bradykinin levels, which is why they do not cause the characteristic dry cough. By blocking angiotensin II activity, ARBs promote vasodilation and reduce aldosterone secretion, leading to lower blood pressure and reduced blood volume. Common ARBs include losartan, valsartan, candesartan, telmisartan, irbesartan, olmesartan, and iprosartan. These drugs are well absorbed orally, highly protein-bound, metabolized in the liver, and eliminated through both urine and feces. ARBs are indicated for hypertension, heart failure, diabetic nephropathy, and as alternatives in patients who cannot tolerate ACE inhibitors. They are contraindicated in pregnancy and in bilateral renal artery stenosis. Side effects are generally mild and may include hyperkalemia, dizziness, hypotension, and headache. Monitoring should focus on blood pressure, kidney function, and potassium levels. Now let's move on to beta blockers. Beta blockers work by blocking beta-adrenergic receptors in the heart and blood vessels. Blocking beta-1 receptors reduces heart rate and myocardial contractility, which lowers cardiac output and subsequently reduces blood pressure. Beta blockers also reduce renin release from the kidneys, leading to decreased activation of the renin-angiotensin-aldosterone system. Non-selective beta blockers also block beta-2 receptors in the lungs and peripheral vasculature, which can cause bronchoconstriction. This makes them unsuitable for patients with asthma or chronic obstructive pulmonary disease. Common beta blockers include atenolol, metoprolol, propranolol, bisoprolol, carvedilol, nadolol, and nebivolol. They are absorbed orally. Some cross the blood-brain barrier due to lipid solubility and are primarily metabolized by the liver with renal excretion. Beta blockers are used in hypertension, heart failure, post-myocardial infarction care, angina, and certain arrhythmias. They are contraindicated in asthma, severe bradycardia, high-degree heart block, and acute decompensated heart failure. Side effects include fatigue, bradycardia, cold extremities, sexual dysfunction, and masking of hypoglycemia in diabetic patients. Monitoring involves checking heart rate, blood pressure, and ECG where necessary. Next are calcium channel blockers, often abbreviated as CCBs. Calcium channel blockers inhibit L-type calcium channels in cardiac and vascular smooth muscle. Dihydropyridine calcium channel blockers primarily act on blood vessels, causing vasodilation and reduced systemic vascular resistance. Examples include amlodipine, nifedipine, felodipine, isradipine, nicardipine, and nimodipine. Non-dihydropyridine calcium channel blockers act mainly on the heart, reducing heart rate and contractility. These include verapamil and diltiazem. By preventing calcium entry into smooth muscle cells, calcium channel blockers reduce contraction, leading to vessel relaxation and lower blood pressure. They are orally absorbed, highly protein-bound, metabolized by hepatic CYP450 enzymes, and excreted via bile and urine. Calcium channel blockers are indicated for hypertension, angina, and certain arrhythmias. Non-dihydropyridines are contraindicated in heart failure with reduced ejection fraction, severe hypotension, and atrioventricular block. Side effects include peripheral edema, flushing, headache, dizziness, and bradycardia with non-dihydropyridines. Monitoring includes blood pressure, heart rate, and ECG when indicated. Now let's discuss diuretics, which lower blood pressure by reducing blood volume through increased sodium and water excretion. There are three major groups of diuretics used in hypertension. Thiazide diuretics inhibit the sodium chloride transporter in the distal convoluted tubule, reducing sodium and water reabsorption. Examples include hydrochlorothiazide, bendroflumethiazide, chlorthalidone, indapamide, metolazone, cepamide, and polythiazide. They are first-line agents in hypertension due to their effectiveness and good tolerability. Side effects include hypokalemia, hyperuricemia, and hyperglycemia, making electrolyte monitoring essential. Loop diuretics act on the loop of Henle by blocking the sodium-potassium chloride transporter, producing powerful diuresis. Examples include furosemide, bumetanide, torsemide, ethacrynic acid, pyritinide, azosamide, and tripamide. They are mainly used in heart failure, pulmonary edema, and severe hypertension. Side effects include hypokalemia, dehydration, hypotension, and ototoxicity at high doses. Potassium-sparing diuretics act in the distal nephron to reduce sodium reabsorption while conserving potassium. Examples include spironolactone, eplerenone, amiloride, triamterene, canrenone, phenyrenone, and mexiletine. They are particularly useful in resistant hypertension and hyperaldosteronism. Side effects include hyperkalemia and gynecomastia with spironolactone. Monitoring requires regular assessment of electrolytes, kidney function, and blood pressure. Many patients require combination therapy to achieve optimal blood pressure control. Common combinations include ACE inhibitors with diuretics, ARBs with calcium channel blockers, and beta blockers with diuretics. Lifestyle modification remains a crucial part of hypertension management, including salt restriction, weight control, regular exercise, and reduced alcohol intake. Patient education is essential to improve adherence, prevent interactions, and detect side effects early. Clinicians must also watch for drug interactions, especially with NSAIDs, potassium supplements, and lithium. To summarize, ACE inhibitors typically end with PRIL, ARBs end with SARTAN, beta blockers end with OLOL, calcium channel blockers often end with DIPINE, and diuretics fall into thiazide, loop, or potassium-sparing categories. Understanding these patterns, their mechanisms, indications, contraindications, and side effects allows you to select the right drug for the right patient safely and confidently. If this video helped you finally understand hypertension medications, like, share, and subscribe to EliteMedicNexus. Turn on the notification bell so you never miss a lesson. Check out our previous video on hypertension mechanisms to understand how these drugs interact with the physiology we discussed today. And stay tuned, because in the next video, I'll show you how to combine these drugs safely in real patients for maximum effect, so you never get confused again.